Just bear with the team for a few moments. Okay, thank you. Members, we're now in open session, and for our evidence session, I'd like to welcome Professor Siobhan O'Neill, the mental health champion for Northern Ireland, and we also welcome Nicola Boyd as well. We thank you both for being here today and appreciate your attendance. Also with us is Ms. Darina Carville, Comptroller and Auditor General for Northern Ireland, Ms. Claire Kane, Director for the Northern Ireland Audit Office, Mr. Roger McCants, Audit Manager, Northern Ireland Audit Office, Mr. Kyle Bingham, Assembly Support Officer for the Northern Ireland Audit Office, Mr. Damien Prenter, Senior Auditor for the Northern Ireland Audit Office, and Ms. Nikita White, Auditor for the Northern Ireland Audit Office. And can also take this opportunity to welcome Stuart Stevenson from the TOA, who's in the gallery. Stuart, you're very welcome to join us, as is all of those with us. Professor O'Neill, very welcome to the Public Accounts Committee. We're very excited about this session. We want to thank you for taking the time to be with us today on this all-important issue. If you could start by outlining your role as the mental health champion and brief the committee before we go to some questions. Thank you.
So, as Mental Health Champion, the office is funded through all of the government departments. They all pay a little amount towards the budget for my office. So I work with all of the government departments, highlighting the priorities in relation to mental health and wellbeing, suicide prevention, resilience across the whole population. The first 3 years, there was a lot of very intense work with health and education and justice, although I did meet most of the other departments at the same time. And one of my key roles in the first year was developing a 10-year mental health strategy. Prior to taking up this role, I'd been working for over 20 years as a Professor of Mental Health Sciences at Ulster University, and during that time I conducted research into mental health and suicide in this population, and we had called for a 10-year mental health strategy, and one of the pieces that I did was a review of all the work that had been done around mental health and mental health reform. So I've been asking for this strategy and also for reform in education and a programme for mental health and education. And as I say, those two actions were achieved. It was a framework for education we developed in the first year, and also then a mental health strategy. So the other aspects of my role are around public communication, which includes media work and doing public work like this where I advise government publicly, and then also campaigns where we focus on the evidence base for well-being. So that's a summary of what I've been up to in the last few years, but it all comes from an academic perspective, looking at an evidence base, and that's why I've got my research officer, Dr. Nicole Bond, who's working in that area and has that expertise as well.
That's very appreciated. Thank you very much. And the members have a number of questions that they would like to put to you, which we appreciate you taking the time to answer. And also, I think we've also want to point out we have a full house of members. Patrick is on via Zoom or Teams, is it? Is he, isn't it Teams? Zoom. It's on Zoom, yeah. So he's on via Zoom, so Patrick's there as well. Okay, members, so if you are happy, we'll go ahead. Is there anything else you'd like to add? No?
No, just I'll take the questions, and if there's anything else I want to say, sure, I can put it in at the end, yeah.
Okay, thank you. Over the last number of weeks since the Assembly returned and this committee formed, we have reflected on quite a number of key areas that are important to the Northern Irish population. And this was a key theme that the committee felt very strongly about, unanimously, might I add, that this is a core issue in each and all of our constituencies and something that needs to be dealt with. So we do appreciate you being here for our first session before we begin the inquiry next week. Also, what is the scale of the mental health challenge in Northern Ireland?
Okay, so the prevalence figures we get from government surveys, And in 2021-22, there was 21% of our population would have scored 4 or more on the GHQ-12, which indicates probable mental illness. So it's a crude enough measure. Now that scale is used in other jurisdictions as well. And what we find when we compare ourselves with other regions of the UK, for example, Scotland is 22%, so they're just a wee bit higher than us. The last figures for England were around the same as ours, and Nicole's done a piece of work where she's analysed some of their data, and they're coming in a bit lower. So we're not the highest. We're similar to some of the other UK regions, but nonetheless it's very worrying. But we need more recent data for England and Wales. When we look at severe mental illness, and those are the people with schizophrenia, bipolar affective disorder, psychosis, patients in lithium therapy, again, the prevalence rates are 9 per 100,000, and that prevalence rate is similar to the other UK regions. So we're not that different in terms of the prevalence, but where the differences are apparent is in relation to the severity of the mental health difficulties and the complexity of the difficulties that we're talking about here. Because of our history of trauma, and my own research has demonstrated this as well, we have more severe and enduring mental illness, more trauma-related mental health difficulties that are therefore more complicated and more difficult to treat. And we certainly need a robust mental health service to meet the needs of that population. So the current cost of poor mental health in Northern Ireland is £3.4 billion annually, and that again, it's the Mental Health Foundation and McDade and Park come up with those figures, and that doesn't include dementia, and much of that cost can be reduced. So I'm pleased that you've taken this as an issue that you're going to look at, because it comes at a significant cost. Much of this is preventable, and of course there's the moral imperative to reduce the suffering caused by poor mental health in our population as well.
That's very, what's important about what you've said there is that the prevalence is similar in other jurisdictions. Have you any figures in relation to the rest of this island, the south of this island, just in terms of looking at that? And also, in terms of services, would it be your opinion, Professor O'Neill, that the services in Northern Ireland are inadequate and I suppose failing our population to date, particularly those who have severe mental health issues?
Okay, so to take your first question, we don't have data in the Republic of Ireland to hand at the minute. We'll go and find that data. I know in terms of suicide, the rates are somewhat similar, although the way it's coded is different, but I'm involved in that work as well in the Republic, and I know that the suicide rates, if you use the way that we classify suicide, it's very, very similar. And our suicide figures are similar to the other UK regions. Some years we're above Scotland, some years we're below Scotland slightly, and we're normally a bit above England in terms of our rates, but they're not the highest there either. Are we failing? We're spending less per head of the population than other regions on mental health services, so that is a problem, and that's been, there's figures for that going back over the last 10 years. So there's been a historic underinvestment in mental health services, and we continue to spend less than other regions, which is unacceptable, obviously. And then, given that fact that our mental illnesses are more complex, then we should arguably be spending more. Now, I have to say that 5 years ago, our rates were higher than and much higher than other parts of the United Kingdom, but those regions have increased their numbers, whereas ours have stayed relatively stable, with the exception of that pandemic year where the scores were higher. So it's not that our rates were better, that we were lying in the past when we said we were the highest. We certainly were the highest. It's that other regions have got worse. Ours has stayed relatively stable. We do have a problem here that needs to be sorted out, and it's costing us every year that we do nothing about this, and we continue to let those waiting lists sit there, and people suffer, and the cost, and the families and the communities of lives that are not fulfilled is huge. We need to be doing something about that. There's also the cost in terms of physical illness, and this is a very interesting one. David McDade gave us figures the last time he spoke in Northern Ireland around the fact that around 50%, that poor mental health adds about 50% to the costs of physical health care. So, this is not just a cost, that is the cost for mental health services. It's making our physical health needs greater as well. So we need to be investing in mental health. We need to be preventing mental illness, because that's the best value for money. But we also need to be treating the people who have mental health difficulties. And those are treatable illnesses, and we wouldn't accept it in any other part of health, so we shouldn't accept it in mental health, especially when we've conditions that there are treatments there for and we're not delivering those treatments. It's not good enough.
That as well is very helpful. In terms of this particular issue, where is the greatest challenge in Northern Ireland in terms of mental health? Is there a particular location that is worse than others, and also is there a trend in terms of, is it mostly young people, is it mostly young men? Are you seeing an upward trajectory in younger people, or what's the information we have around that?
Where is it? Well, the costs are borne mostly in terms of depression. I pull them out here. So most of that cost is for depression. A lot of the cost is actually borne by the carers of people who are unable to work because they're caring. I think it's over 30%, 36% or something of those costs are carers. So you've got a lot of costs that come with the common mental illness. Obviously, the severe and enduring mental illness, the schizophrenia, psychosis, bipolar, people requiring hospitalisation, again, that's very, very costly. So you've lower numbers, but it's very, very expensive to treat those individuals. And again, with early intervention and psychosis, there's strong evidence that will make a huge difference, and that will save you further down the line. So the costs are borne by, in terms of suicide, of course, it's 3/4 males, around a quarter female, but actually there's more women than men would be screening positive for depression on our population surveys. So, it depends where you look, but certainly, again, the evidence shows us that 50% of those cases of mental illness, there'll be evidence of that by the time that person's 14 years of age, and certainly it goes up to 75% by the mid-20s. So whenever you're thinking about preventing mental illness or getting in early and giving the person, the best chance, you would direct your money towards those younger age groups in there. And we know, especially in the early years, the first 3 or 4 years of life, very, very important, the attachments, the relationships and families there, and adversities in that period are very predictive of the development of mental illness throughout the lifespan. Childhood adversities, ACEs, we sometimes call them ACEs, and trauma in that period leads to mental illness later in life. But we can identify the symptoms by the age of 14. So you can see why education is such an important setting to be doing this work, to be identifying people who have the early signs of poor mental health and getting them the treatments that they need.
Okay, thank you. I'm going to go to members. Does anyone want to follow up on what I've said there, or we're happy enough to move on?
Sure.
Dave?
Just a brief one in relation to the figure identified that total referrals remained around 1/5 below pre-pandemic levels. Mm-hmm. What's your take on why that remains the case? Does it represent a ticking time bomb there in terms of people not coming forward? Is there potential that people aren't coming forward because there's just so much of a waiting list, people aren't confident they're going to get help?
Very, very difficult to know. We don't know. We don't have the data on that. Maybe it is that people have come forward and now, people are talking more about their mental health and are disclosing poor mental health, so they're on those lists, or they may have lost faith in the system and may not be coming forward. I don't have the answer to that. We'll go and have a look at it, and we'll come back to you if there's any data that we can find that helps understand why. And it may be just that the need isn't as great as it was. If more people come forward, it does plateau eventually. But that doesn't mean we need to start treating all the people that are on the waiting lists right now. That's fundamental.
David?
Just before I go on to my question, is it possible that outside sort of charities are carrying a lot of that rather than the professional health service, if you like? Is that
the non-statutory? Yeah. So you're saying people are going to the community and voluntary sector or the private sector? You know, and there is evidence that that's happening. And as I say, the mental health strategy has the vision for the single regional mental health service that includes the C&V sector, where you have data across all, you know, so you would have that data. But we don't have that data collated across the C&V sector at the minute. But you're right. And through the pandemic, the C&V sector responded in a very agile way, and we're able to meet the needs of people. And we're now seeing that the funding has dropped off there, you know, and again, that's a real problem that we're seeing.
Yeah, I know one of my own constituency, and the actual GPs just refer them straight to and then it's a free service for the health service. You know, so it's just kind of ironic. But listen, just quickly then to move on. That so you're saying with higher and more complicated need and trauma and numbers of need, yet with significantly lower percentage of funding than that of GB and the rest of the island. As mental health champion, do you have any indication of what level of funding is needed and what level of funding we should be looking at?
Yeah, well, what we need is transformation of the mental health service as outlined in the mental health strategy, and that strategy has the funding plan that it's attached to it. So if you were to implement that strategy, that would be your starting point. So there's two sides of it. There's the strategy, which is the plan to transform the service and create a single regional service. And then there's the spend on mental health services that we're, you know, what we're spending every year on mental health services. So what do we have in terms of expenditure? So 13 million every year on antidepressants. Total expenditure for mental health is 359 million, and it's 6.8% of the overall health and social care expenditure. You look at other regions, and other estimates would tell you that should be around 10%, 11%, you know, depending on how you calculate this. So at the minute, it's 6.8% of the overall health budget is spent on mental health. So you could estimate very crudely that needs to go up to about 10%. But then, you know, you've got to look at the overall budget and say, well, is that budget accurate there as well? Equally with CAMS, with children and young people, the idea is that would be 10% of your mental health budget. But again, for me, I would prefer those estimates to be based on need, rather than just looking at what is spent in other regions, you know. But that's, you know, we're underspending, no matter what way you look at it, we're underspending on mental health services. Now, the strategy needs to be layered on top of that, because you need that extra money to transform the system, to bring together all the trusts, to create a regional service, to create the new services that we need to provide a functioning mental health service that meets the needs of the population, you know. And that is in the funding plan, and that overall it will be a third more than we're spending, and that's, you know, that's figures that we came up with a couple of years ago. We'd need to be spending a third more, but it would be worth it to transform the system. In terms of funding on the strategy, in 23-24 we needed 24.38 million. That's what was in the funding plan, and what we spent was 5.5 million. Right, 24-25, which is that's where we are now. We need 42.08 million for the strategy, and we don't know how much is going to be spent on it in reality. My concern would be that it would be a lot less than that, you know. In 25-26 we need 61 million for the strategy. It goes up every year. What we actually need is a 3-year budget at least, so that we can say, this is what we're going to deliver on the strategy, showing how the investment will stack up year and year and year, so we can get where we want to be in 10 years' time. 5.5 million every year is not going to cut it. It really isn't. We've been able to do a lot of great planning work. Now we need to put more money so that we can build on that. And I can tell you more about what that should look like and where that money needs to be spent.
Just have a couple of more
Sure.
things to put out. But I think I'm right in saying you said that in other areas of GB that there was a 50 when the percentages are spent on mental health, there was a 50% drop or whatever in physical health. I think that's what you said earlier. Spent in physical health.
Yeah, per mental health adds 50% to the cost of physical health care. So
Right, okay. So
helping people with physical health problems, supporting them with their mental health will reduce the cost to physical health.
So what of the other regions, when they've spent more on mental health, what are the outcomes of that within the rest of their health service?
Okay, I can give you some figures for that. So it depends how you spend it, obviously. Let me get this. So here we go. So something like workplace well-being. For every pound you put in, you get 2.37 back. Suicide prevention, 39.11. These are 2017 figures. So there's collaborative care for physical health problems, 1.52. So if you invest, depends where you put your money there. Anti-bullying in schools, 1.58. School social and emotional learning, 5.08. So obviously by treating mental illness, you're reducing the cost to the mental health budgets. But if you invest money in other aspects of the system, then you get your money back in terms of that investment.
And just a couple more. Other reports have shown that we have patients staying much longer in hospital, which is significant cost. Is this making the mental health problem worse? Is there a connection between the amount of time people are spending on the mental health hit? No? Or
I wouldn't say that. I think the waiting lists for psychological therapies are a real problem because we know psychological therapies work. They're effective treatments, but if you have somebody waiting for 2 years on a treatment for any condition, whether it's physical, they're going to deteriorate, but particularly in terms of mental health, they'll deteriorate. So you do all the good work with them in hospital, doing the stabilisation piece. So, you want them to move out into the community as soon as possible, get them back into their environment that they're going to be in, and you want to deliver the psychological therapy, and that's not happening. And of course there's the social care that needs to be in place there for some of those patients as well, and the services need to be there in the community. So the delays in discharge are a real problem, but we have a huge problem in terms of access and psychological therapies, and that's causing problems. People are getting worse. It's more costly, and we just don't have the staff to do it.
Thank you. John? Sorry.
Yeah, thanks, Chair. Firstly, Professor O'Neill, just want to thank you and your office for all the work you're doing. It is a massive undertaking, and we appreciate everything that you do. I just want to come in on the aspect you talked about prevention and early intervention, and particularly CAMS. The last figures that we heard was almost 3,000 children are waiting for mental health services in Northern Ireland, and over half of those are waiting over 9 weeks. Anecdotally, certainly to my office, I'm seeing that feels like it's increasing, and the access, particularly for parents to get that, is increasing, become more and more difficult. I'm just wanting to know from your experience how difficult that is, and what you're feeling in terms of the improvements could be.
So for children and young people's, what we're seeing on the ground is that the young people are getting to a service later than you would have had in the past, and I'm thinking particularly around eating disorders, and they're much more seriously ill by the time they get help. And then also when parents present early with a young person who's showing signs of anxiety or depression, or they're struggling, they can't get the help for that young person. And they're not eligible for child and adolescent mental health services because their needs are not significant enough, because that child hasn't developed a full-blown mental illness. So they may be in that group of young people who before the age of 14 are showing the signs of poor mental health, but they haven't met the criteria for a mental illness. And it's almost as if that earlier intervention, if you were looking at a step care model, it would be steps 1 and 2, that the services aren't there. And that's why we need to have the joined up working with education. We need to have new posts like the clinical associate psychologist posts. These are posts that are being developed right now, but we need to make sure that we have psychological wellbeing practitioners, CAPs working there to do the early intervention work. We need the therapy hubs to be operational, the multidisciplinary teams to work well, so that young people who are showing the signs of poor mental health can get treatment earlier. As I say, a lot of the referrals that are going through to CAMHS are being bounced back, because they're inappropriate referrals. So that is a significant concern. And when you have a young person as well, I would use the phrase like time critical. It's important that you get them help urgently. You can prevent a problem from developing, but also in terms of their education, you're leading to poorer outcomes there if they have to wait, because they will struggle at school if they have poor mental health. They will struggle with their friendships, with their social development. So it's absolutely vital that young people get the help they need, which is one of the things, about the Healthy Happy Minds. That was a programme of interventions that was working there. And we have some great work happening between health and education. There's just not enough of it, But when children get the help they need, they flourish. It's a game changer, and it prevents problems further down the line.
Well, Chair, that takes me to my next point, and thank you for that. I mean, there's a clear case of invest to save. The more we put into this, ultimately, the more we save. You made the economic impact assessment of mental health in Northern Ireland is vast. So if we can tackle the problem head on the earliest possible way, the amount of money that could be saved is astronomical. So to that end, is the strategy, do you think, ambitious enough in tackling children and adolescent mental health issues, and is 10% of the budget enough, given how much of a game changer that could be? And the final point to that is, and this is my last question, what are the areas of best practice that you've seen elsewhere in the UK, in these islands and elsewhere, that we could replicate, if possible, here to tackle children's mental health problems?
Okay, so in terms of the adequacy of the mental health strategy, the strategy itself is it's excellent, but it's a single department, really. And what I want to see is a programme for government which prioritises wellbeing, and prioritises children's wellbeing, and really focuses on that, because that's what we need. We need to be improving the experience generally for children and young people in Northern Ireland, and that's a programme for government issue. So as a health strategy, this is an excellent strategy, but we need now to match it in our programme for government. We need to focus on child poverty. Eliminating child poverty is key to this issue, in terms of adversities, deprivation, inequalities. So that's one thing, but I think it's really impressive that we have such a strong Department of Health strategy here that we can work from, and we need to now operationalise this, implement it. One of the things, you ask about the child and adolescent mental health, one of the things we need is a workforce that's able to meet the needs of our children and young people, and we don't have that. So if we increased our expenditure in CAMHS at the minute right up to that 10%, my fear is that what we would really be doing is taking people out of the C&V sector. We'd be taking people out of other parts of the mental health service, and we don't have any child psychotherapy in Northern Ireland at all, no commissioned child psychotherapy services, and that's just not good enough. We need to be training more practitioners to work with children and young people, which is why the CAP posts that I was talking about, that was so impressive, because that's children and young people. We need a lot more of that. We need to be able to provide psychological therapies for children and young people and their families, and we need to be investing in support for parenting as well. How parents and families work as part of this. And so it's not just about therapy for the child, it's never that. These are play therapies, arts therapies, they're therapies that work with the whole families, that work on the attachment issues that are the foundation of good mental health.
Just to pick up on the workforce issue, and it is key, and I know this from my time in the Health Committee, there's an old truism out there within health, no staff, no services. And I do want to focus probably on the health. I realise there's education and all other sorts of ones. However, the workforce review has indicated 2,000 vacancies within that, and 500 nurses needing, and there's a long tail to providing those. There's training places. It takes a minimum of 3 years. You have all that education and training to support. We have a current situation where people really, you're robbing Peter to pay Paul. Statutory services are looking for them, private sector is looking for them, voluntary and community. So given those pressures, and we've also seen a situation where there's been significant underspend in areas over years as a result of not having staff. Yes. So you cannot provide the service well. So are you satisfied, Professor, that the Department of Health are acting urgently enough to bring forward the planning and the actions needed to get that workforce into place?
Okay, so the workforce review happened very, very quickly. You know, and these things don't cost a lot. So this is one of the first things that happened, was a workforce review for the statutory side of things. So we need the community and voluntary sector workforce review, but the statutory one is there, it's available, and there needs to be a 45% increase overall in the workforce for statutory services. And if you look in that workforce review, you can see the percentage increases we need across the professional groups, right? So I have no, you know, this was done very, very quickly, and it's a really strong document, you know, and it involved all the right professional bodies. Now we need an implementation plan for this, but what we need is the commissioning of training places. This will become out of date in a few years' time. So it's so important and vital that we move now to do the next stage of this, which is the implementation plan and the commissioning of training places. And what I'm saying also is that we need a lead psychological officer or a chief psychologist or someone whose job it is to scope out the psychological therapies or the non-pharmaceutical interventions, to look at who we have out there who's able to work in the mental health service to deliver these sorts of therapies, psychologists, counsellors, PWPs, CAP, so who's out there and where can we get them in, and how quickly can we respond to meet the needs in terms of psychological therapies, because that's where the gaps are. When we're talking about long waiting lists, it's not a waiting list for antidepressants, it's not a waiting list for medication, it's a waiting list for therapy. It's a waiting list for counselling or psychotherapy, and that's what people want. Now, I'm not saying that everybody needs psychotherapy, and not everybody does, and there are other really effective treatments, but you know, people are waiting far too long to get anything that's not a medication, and that again is a huge, huge problem.
What my question really is the department doing enough currently to make sure that starts to happen? To lift it off, no understanding the problem, and move it into addressing the problem.
So we have a strategic reform board coming up where I will see the implementation, the plans really for the strategy for the next year. I think they've done all they can last year with the budget and everything and the instability that we've had. But now we have more clarity around budgets. We should be moving more quickly. So come back to me in a month or 6 weeks and I'll be able to tell you what the implementation plan is for this coming year. Because for me, it needs to be workforce training places and having somebody in that job that you can go to them and say, right, what's happening with our psychologists? What about the psychiatry vacancies? You know, vacancies across the system there, 25% vacancies in psychiatry. So we need that person in place and we need to get moving. But it's very early days. So I can't say they're not doing enough, Colin, basically is what I'm saying. But, you know, I'll be able to tell you in a few months' time.
Okay, thank you. Colin Cahill.
Thanks, Chair, and Siobhan, you're very welcome, and Nicole. And you're very glowing there about the strategy, so I want to stick to strategy. Now, I mean, you know, it's a 35 action plan right across the board. Obviously comes at a massive cost, which is unaffordable to the department at the minute. So my question to you is, as mental health champion, do you think this strategy, bearing in mind the answers you've given so far with workforce, do you think this strategy is deliverable?
It depends on the budget. And it's not even this coming year, because I know that's going to be a 1-year budget, but after that we're going to be looking at 3-year budgets, and we will know when we get that first 3-year budget how much of this can be delivered, and then we're going to have to look at that strategy and think about what really is doable. So it is still too early to say. You know, it's just that the fact that we don't know what the budget's going to be. I think we've lost some time now, in fairness. So it's hard, you know, whenever you're at year 3 of a strategy and there hasn't been enough investment, but we can catch up. I think it's possible to catch up. I'm very optimistic that we can catch up, at least some of this, you know, it's not. But will we get where we need to be in 10 years without a 3-year budget after this year? Probably not.
Okay, because I want to focus on the strategy, because we're delighted that we started off for this inquiry because it's most important. So at the end of this process, we hope to be able to develop some recommendations and work with the department to deliver it across the board. My second question, given the limited resources, from your perspective, what are the priority areas within the strategy?
Okay, so to no surprise, workforce has to be the priority, and psychological therapies workforce getting the lead person in there to do that, to develop that side of the workforce is fundamental. I would then go to the other end, which is crisis intervention services. So the regional crisis intervention service model was developed and launched in the first couple of years of that strategy, and there's good progress has been made mapping out what crisis services are there. So the regional crisis intervention service is really a way of bringing together all of the different strands. So you have the primary care out of ours, you've got mental health liaison, you've got the ambulance, police, rescue services, all of those people, and community services that are dealing with individuals in crisis. So it's really creating a regional model that provides alternatives to emergency departments. And the really important piece of that is the C&V sector response for people who don't require a hospital admission, who don't have a diagnosable mental illness where they need mental health service statutory services, but they do need something. In Scotland, they have a project called Distress Brief Intervention, DBI Scotland. They provide 14 days of community and voluntary sector follow-up for people who are in crisis. And this is suicide prevention care. It's problem solving. It's working out what led to that point of crisis and helping that person get the care that they need. That's the missing piece of the puzzle that we don't have. We have MAT teams, we have community navigators, we have crisis services who do de-escalation. It's the follow-up. So that is another priority area for me, the crisis service. And then the other one would be early intervention and prevention. We again have a plan that was developed in the past couple of years for early intervention and prevention, and we need to now be moving faster as we go through that plan. There's a lot of work already been undertaken there, so that is another priority for me. And then the final priority would be the creation of that regional mental health service. Again, we have the groundwork, we have a model. We now need to work with the C&V sector to make sure that they are part of the service. The head of the mental health service has been appointed. We need to get the head of the service to provide that regional collaborative boards, to set up that regional structure. You know, so that's fundamental. None of these things, if you note, are going to cost a lot, and we won't need the full amount that's in the funding plan for those priority actions. So if we could get the full amount, then I would be saying, let's do more of that. But if you look at those 4/5 actions, depending on how you lay them out, that would be the best way to spend the money that we have, so we would get the best benefit and help the most people and save ourselves money down the line.
Okay, and just final question, Chair, in terms of the strategy, 3 years in, 7 to go, where are we on the scale? We haven't spent what we needed to spend, you know, so we're not as far forward as we should be, but we have some impressive plans. We have a regional outcomes framework. People are asking me data and outcomes. We have a framework that's good to go, that will work really well, measuring people's experiences of services and the outcomes, and how services are performing. We have the workforce review, we have the regional crisis intervention service. I think we're doing really well given the context, but we need to be people aren't feeling the difference in the ground, and that's what's worrying me. We need more people on the ground delivering services and delivering those therapies. And that's what's worrying us as well, so to be honest.
Yeah, and that's what I hope that you can help with.
Thank you, Chair.
Thank you, Professor Neil. Tom?
Thank you. Thank you for being with us today. Accessing services and obtaining treatment is one of the huge barriers that's facing mental health patients today. As mental health champion, what are you hearing from these people, the service or the users? What are you hearing about their experiences regarding these barriers, and in what areas of service do you see particular problems that needs to be addressed?
That's a great question, because this is part of my job, is to engage with people on the ground, and they come to me all the time and they're saying the help isn't there and they're having difficulty navigating services. So even as a starting point, a lot of people will be trying to access services by going to their GP, and remember, primary care deals with a lot of this as well. So getting a GP appointment can be a difficulty, and then a referral to adult mental health services or child and adolescent mental health services, the waiting list then to be seen can be excessive. So it's long waiting times, and then they are assessed and they're told that either their needs are too complex, so they may have an addiction or be a substance user, and then they find that the services aren't suitable for their needs for that reason, or they may be neurodivergent or suspected to have ADHD. And there's no way in some of our trusts of having that diagnosed. So that's a problem. There's literally no service for that. Or they're sent to a service that's inadequate. Or someone with an eating disorder is sent to a hospital and they're admitted to a hospital and they don't get any sort of psychological care. It's purely physical care. So it depends on what you're talking about. And then we have people when they get to the stage of getting services, they're saying, well, you have mild depression, really, we're not the service for you. So they go back then into the community and voluntary sector, or they approach a C&V sector organisation themselves and they find they're on another waiting list, or they attempt to go private and then they're looking through lists from professional bodies and thinking, how much is this going to cost? Or they simply ask for a prescription, something to settle them, from the GP, and that's the option that they choose. So it is literally all over the place. Some people receive excellent care, I have to say that, and those cases rarely make the news, because they don't complain. So I've heard many cases of people with very complex addiction and mental health problems who are getting excellent services, who have turned their lives around, who are back working again, who are fulfilling roles within families and being a parent in the way they want to, and that's amazing when you see that. And there are many cases, and I go out and visit the different services and I hear about the work that they're doing and the care that they're providing, but just getting to the point where you can get the service that provides the treatment that you need can be a real difficulty. And often, you would hear of suicides, of people who get a lot worse, who end up needing hospitalisation, but they've asked for help at an earlier stage, but they weren't able to navigate the system and get the help that they need. So our services are doing their best, but there are significant gaps, and many of our most vulnerable people don't get the care that they deserve and that they need.
For those that are in that position and they're waiting and they're seeking help, they're crying out for help, we see them we get them in the office, they're not getting the help that's required, the waiting lists are continuing to grow. What then, in your opinion, can be done to improve this situation?
Well, as I say, what we need is reform of the whole service, and that is the mental health strategy. It's the workforce. Fundamentally, when we look at the psychology, 30% vacancy rates across all of the trusts. So we're working with a third less psychologists than we should have, and this is not funding in and of itself is not going to solve that problem. We need to increase training. We need to make sure that our universities are training enough people every year. We have 500 plus psychology graduates every single year, and yet I think we have around 21 places, 250 applicants for every place. The situation with psychiatry, 16.4% vacant or unfilled consultant posts, more than double than you would have in the United Kingdom, 7%. So the vacancies are a difficulty. Training is a problem. It is a problem. So when I say the strategy, I don't mean setting up a new service per se, although we need new services too, but I mean working from the ground up, setting the structures. We have the plans, now we need the structures, the training places, the people on the ground to deliver the care. So the strategy is where it's at, but we just need more money for the services as well, but really the strategy is the solution as I see it. And people with lived experience have worked, they've put energy into the strategy. They've given time, they've given themselves to it as well. So we owe it to them to do it right.
I think this is an important area, and I think most MLAs in this building would say that their constituents, Professor O'Neill, are saying that the obstacle that they are facing is, yes, there's issues with treatment generally, but I mean accessing the actual service. We often say there's help out there, just ask.
Yeah.
But when they go looking for the help, the criticism is that the help is not there. They cannot find the door. And A&E is not the right place for people that are in that vulnerable state that needs that help and assistance. Would you agree with that?
It is for some of them. You know, if someone has injured themselves or they've attempted suicide and they need a medical assessment, or they need an assessment if they're showing signs of psychosis, they do need to go to an emergency department or another safe place where they can get that assessment, that psychiatry assessment. So if someone needs a hospital admission, then the emergency department is the right place for them. But there's so many people that are outside of that who are in crisis, and that's where the regional crisis intervention service comes into play, because it does provide those alternatives. Now, in many parts of Northern Ireland, there are alternatives there. There's the multi-agency triage teams. There's community navigators who work in the emergency departments who help people find the right sources of help. There's community crisis services. There's Lifeline, which would be the suicide prevention helpline, 0808 808 8000. So, there's all of those other services, and it's really important that people do present so that we can get them the help that they need, especially if they're in suicidal crisis, because that's a death that can be prevented. So we need that whole regional crisis intervention service, including the C&V sector follow-up, the problem-solving bit, the 14 days, starting the morning after. We need that in Northern Ireland, and that's the bit that's not there. But in any society, an emergency department should be able to help someone who has attempted suicide, who is in suicidal crisis. But we need to get them that follow-up and the treatment for the condition that they have, or the problem solving for whatever it is that has led them to that point of crisis. Recognising that some of these crises are not mental illness. People may feel that things, they're very, very distressed, but it might not be a mental illness, but they still need support and help there. And many of them have substance use difficulties and addictions that need to be dealt with there as well.
There's a number of points in relation to that, Professor Neil, and I do appreciate your answer in relation to it. If a young person or any person presents to our office today and says they can't get access to their GP, that are struggling with mental health, and remember, anyone's mental health can deteriorate in an instant depending on the circumstances, the challenges they face in our society on a daily basis. So they can't get access to GP, and you ring mental health services in your local town or constituency and they say, they're not known to us, we cannot see them, go to A&E. If that person is struggling with severe anxiety, send them in the context of A&E at Altnagalvin, for instance. That is not the best place for, would you say that is not the best place for that individual in a very difficult, busy environment where staff are overworked, and again we touched on workforce already. I am aware of people that are sitting in those states for 2 days at least.
Oh, no, absolutely. And anxiety is not a condition that would be treated in an emergency department. Someone with anxiety, ideally, a multidisciplinary team in primary care would have a mental health worker there who would be able to see that person, that they could get an appointment with a mental health worker. And this does happen in many of the GP federations. So someone who's struggling will get an appointment. Now, it's not a 24-hour thing, obviously, but they see that person and then they can get an assessment that way, but it's getting, if it's anxiety, so what's the treatment going to be? Does it require a treatment, and where does that person go next? That can be a problem. But anxiety in an emergency department, no, probably not. But significant distress, hearing voices, those sorts of things, yes. Suicide attempt, yes. So it's good that you made that differentiation.
And I just want to probe about that, because this is very important, because this is something we're hearing about on a daily basis. If someone that's in that very fragile state of mind is presented to A&E on a Saturday, because they've nowhere else to go really, and they're sat in a waiting room surrounded by a huge number of people that may be intoxicated, people that are severely ill, people with dementia and all the rest, and it's adding, I've been told, to their situation, making it worse. Often they don't remain in the A&E because the waiting times are so significant at that stage. What way do you see we resolve that? Is A&E really the most appropriate? If there is no physical injury, is it really the most appropriate place to send those people in that very vulnerable state at that time?
No, I would agree with you. It's not, and actually, it can lead to an escalation in anxiety, because it's an anxiety-provoking environment. It can also lead to hopelessness. This is where I go, well, there's nothing for me, and this idea of ask for help, I've done all the stuff that you've told me to do, it's okay not to be okay, I've asked for help, and now this is what I get. That makes, so it makes it worse arguably for some of those individuals, it's not the right place to go, and that regional crisis intervention service model provides an alternative. Or an alternative to get them out of A&E very quickly, somewhere else, or ideally that they don't go to A&E at all, that they can ring an agency like Lifeline, or if they're in touch with the ambulance service, that they can either be brought somewhere else, and that's where we're talking about the C&V sector services. And as I say, there are those alternatives. There's also the cafe model, the high street cafe model, the wellbeing cafe, crisis cafes operate again, the sort of a place where people can come when they're in a state of distress or crisis, or when they feel that they need support. And ideally that's, it's identifying the signs that something's about to escalate and getting the support early. And those models operate in various parts of Northern Ireland really, really effectively, and they're staffed by clinicians and professionals who really know what they're doing there and can help people. But we need that across all Northern Ireland, which is why this regional crisis intervention service that I keep banging on is why it's so important, and the work has been done there, and there's other places that are using this, and evaluations from other places that we can use to say, well, this is how it works and why it works, and that it does work well. So that's what I'm advocating for. We have the solution for some of this, yes.
Okay, thank you. Cal, briefly.
Just quickly on this, Chair, it was interesting. When you keep talking about the workforce, tell me this: how do we retain the people we have on? Secondly, how do we encourage or incentivise people to come into the sector? Because we're all here day and daily. So, just your views on that, please.
So by retaining, the staff that I have engaged with, and there have been so many, they're there because they want to be there. They could, go into the private sector. They can find jobs elsewhere. Majority of them. So they're there because they want to be. They want to help people. So retaining them is about giving them the hope that we will change the system, that we will make things better. They know the strategy's there, but often they just don't believe that anything can happen. Even when you show them the models, and they talk to me, and I try and be optimistic, but I think that's all we need to do. They've stuck it out this far. They want to help people, and they find the work really, really rewarding because that's what they do. So they would have left, in a sense. And in terms of the mental health workforce, attracting people into the workforce, the psychologists and psychiatrists tell me there's no shortage of applicants for the positions that they have. This is not about attracting people in necessarily. And I know that people can go elsewhere, and they do, but this is about increasing the training places. I meet psychology students all the time and have conversations with them. They want to work as part of the mental health workforce. Any way in at all that they can get in, and they're prepared, and the commitment and the passion and the motivation that they have to help people, because that's what they've chosen as their career. So let's just expand the training places so that we can get more people into the workforce and do the job of reforming the system, so that we can use the people that we have, and we can use the skills that we're creating here, and the people who are already out there. There's counsellors out there who can't apply for jobs within the system, for example, as well. So there's a lot of task shifting and work that needs to be done to scope out who's there and who wants to be involved in getting them in. And yes, all of that, the reform, as it starts to happen, perinatal mental health services, that's been a real joy, watching that. And it has given people that hope and optimism. And we've finally seen services in every single trust. We still need the mother and baby unit, but the fact the services are there, that's a sign that things can change. So that is our spark of light and hope. So we need to be doing more of those, lighting little fires, as somebody said the other day, across mental health, as evidence of the change that's happening that we can create. But it will take money to do this, but it is money well spent.
Thank you, Cal. Thank you, Dan.
Thank you, and thanks very much, Siobhan, for being here. Really appreciate getting the chance to have the expert evidence ahead of such an important inquiry. I want to speak specifically on data and outcomes. So reviews have highlighted there's a real lack of data to monitor the service activity, especially measuring service effectiveness and user outcomes. In your role, where you report that you're working towards improving mental health of everyone throughout all aspects of life, how do you measure improvements with the lack of data that we're seeing?
Okay, so the government surveys, the GHQ, that's a really important one, you know. But we need to be doing more in-depth work. And a couple of years, 2019, there was the childhood prevalence study, which was the very first epidemiological study of mental health conditions and risk factors across our children and young people. And that was a really, really important study. Then the pandemic happened, so all of those prevalence rates that we have for things like ADHD, disordered eating and eating disorders, mental illness, anxiety disorders, all of that stuff was in there. So that's our, you know, our depth stuff. What got me into this work was in 2005 when we did the Northern Ireland Study of Health and Stress, where we looked at the prevalence of trauma and depression and psychoses and all of those. So we need more of those prevalence studies, those epidemiological studies, and the government surveys are very useful. In terms of getting data from Department of Health, the difficulty that we have is that we have the trusts and they're all collecting data, and their definitions are different. So, you know, and journalists will come to us and say, well, we've got this, we can't make head nor tail of it. We've asked about waiting lists, so we don't know what counts as, when does someone go on the waiting list? Is that a referral, or is that, you know, so it's just very messy. There's a lot of data there. We have the Administrative Data Research Centre who are working to link data sets. We have a lot of academics who are interested in analysing this data. We need to bring it together better. And one of the things, this was identified in the mental health strategy as an action, and we've actually created the regional outcomes framework. It hasn't been launched. I don't think it's publicly available, but that is the plan, to bring together all of the data. So we have there's 3 pillars. I'm just reading directly from it here: access, numbers, waiting times. So how many people are out there with mental health problems? What are the waiting times? Who's trying to access services? Then we have acceptability, patients' experience of care. That's really, really important. When you ask, you know, people go through their treatments, they're discharged out the other end, particularly in CAMHS. Some of the evidence says maybe about a third of them feel that they're no better than they were when they got, and you know, that's not good enough. So how well mental health services did for them, were their needs met? They're on a journey to recovery. It's more complex than just getting a treatment, you know, but that's in our regional outcomes framework. And then we've got effectiveness and efficacy, and that's where you get your symptom level changes or your treatments. So that regional outcomes framework is there. We need to implement that. It's going to be costly. We're waiting on the Encompass systems as well to be embedded across all of the trusts, because you need those mechanisms working. But that regional outcomes framework is the answer to a lot of the difficulties that we have around data at the minute. So I have to say, we were told about this yesterday, and we asked Department of Health yesterday for some up-to-date information, and they came back to us straight away in terms of expenditure and proportions and all of that stuff. So, you know, there's data that's available, and good data, but we need that regional outcomes framework so we get data across access, acceptability and effectiveness. And that's where we need to be. But we need to be doing more of those prevalence studies as well, you know, to work out where we're sitting, and we need to follow up for the children and young people's one at least, so we can find out, because my sense is that things have got a lot worse, and there's a lot of hidden poor mental health there that we're not capturing, and we need to be designing a service that meets the needs of people on the ground as well.
Thank you. And the framework certainly seems to be the on paper answer to the way forward, but it's not where we are, unfortunately. So just in terms of, so in your annual report 22-23, you talk about providing advice and improvements on performance with both the Department of Health and the trusts. So I just wanted to ask, you talked about the complexity of the data. Mm-hmm. Are all the trusts collating and measuring their data in the same way as each other?
It's very difficult to know.
Okay.
So, and we get this, it mainly comes from journalists who do FOIs with the trusts, and then they come to us to try and explain this after, and I be sort of looking at it going, what question did you ask that generated these figures? And then it's very difficult to compare. So we can go back then and ask, how do you define this, and what counts as that? And then you have people across, there's people being sent to different trusts for treatment. So that makes it even more complex, because there could be double counting within the system as well. So I'm not saying that the trusts are doing anything wrong here, but what we need is that regional mental health service and the regional outcomes framework to make sure that everybody's doing everything in the same way, and then we can start to make those comparisons. But where you've trusts, they use different models, so the services aren't the same in all of the trusts too. So you could have a long waiting list in one trust, but that might mean that they're grouping together various different groups that are separated out in a different trust. So it's a nightmare at the minute, but we have the plan to solve this, I suppose, is what I'm saying.
So that's it makes it seem even worse than what I had imagined, to be perfectly honest. No, but it's good to get the feel for what you're actually dealing with.
I think that's
here.
a theme, though, of everything
absolutely.
here.
And it's really good to get that clarity in terms of you as a professional user, as the mental health champion, as a professor in the field, that you're finding the data this complicated to be able to put together and compare on it.
Can I tell you what we've done, though, and we're launching it soon? We've just done a population survey and asking how many people out there have tried to access mental health services, and how long have you waited, and where have you went. So we've gone about it the other way, and I don't have the figures in front of me, because they're just, we need to do the tables, but we're presenting that data, and Nicole's been working really hard on that. So we've tried to circumvent it and find out ourselves what it's like on the ground for people, and I think that's the sort of data that's going to be really useful too.
That's brilliant, and it's great that you're taking that initiative.
Sorry, just to add the framework, there is a subgroup as well that's focused on data and outcomes, and we would sit on it. I think there's about 100 members at this stage, but there's a smaller working group as well, and it would be the people that create those population level surveys, academics, people with lived experience, people from the C&V sector, and it really is trying to get everybody into one room to decide, how do you actually record your data, what do you need, because we're looking at this from a mental health perspective, and we want these outcomes within the framework for a mental health perspective, but they weren't set up to measure that. Like the population surveys, the health surveys are a wider remit than that, so we're picking sections out of it. But it's trying to identify what is already there, because there is quite a lot of data there. It is just the disjointedness of it that's difficult to put together, but there's work being done to try and hone that in, to identify which markers we will use at a population level and which markers at a practice service delivery level people should be incorporating into those reports, so that the wider public can get that insight. So it's scary, yes, but there's a lot of work being done to try and figure out how to streamline it.
Oh, absolutely, because if you have a whole lot of data but it's not available for analysis or meaningfulness, you're not really using it effectively at all. And we're talking about measuring the effectiveness of outcomes, because I was going to ask you in and around regional disparity, but it sounds like we're not even in a position to recognise if there's parts of Northern Ireland that are worse than others, because the data is incomparable, which is very, very concerning. As a representative from a rural constituency, who I certainly get the feeling from my constituents, experience even more significant barriers, but there's no data to back up that case, in particular areas. So it's just, and again, in terms of the data being this way, I was going to also ask, are we able to benchmark our service delivery and outcomes with other areas? But again, I feel like you've already answered it, because the quality of the data, you can't. Elsewhere in this report, we're benchmarking against other parts of these islands as to how much money is spent in Northern Ireland in mental health. But if we can't benchmark the outcomes with anywhere else, it's just leaves it very challenging. And just had one final question I wanted to ask you. It was, do you know, is there any? I'm really afraid to ask anymore, but do you know, is there any data held or collected from the department or the trusts on how many direct referrals they make to voluntary and community sector organisations?
Not consistently. So there might be data there, but again, it's not consistent. I know from children and young person perspective, we were working with the Children and Young People Strategy team that were set up with the Children's Service Cooperation Act has in it that there would be pooling of resources for services that relating to children and young people, and there's a function within that departments can share those resources and identify when referrals are made. And CMV Sectors is listed as one of those organisations, but obviously there's so many of them, how they access that is difficult. They were working on a piece to see if that function's ever been used and how it would be used. Like, we know how much of the services are commissioned, and there's kind of core funding that would go onto it, but as one of the other members here highlighted, some of the trusts are using the CMV sector resources because they're quite strong in certain areas, and they know that they'll be seen quicker and that they'll get that more place-based support. So really, it's not consistent. We don't have a way forward, but it is part of the plan to map where those resources are.
No, absolutely, because and then again, particularly in rural areas, I know when we faced the cliff edge last year, the trust have literally nowhere else to refer these patients to in certain parts of Northern Ireland other than the voluntary community sector. So, you know, there's thousands of people sitting on that cliff edge, so it's important to capture it. But thank you very, very much for your evidence today. I really appreciate it. It's really important.
I think Diane's questions point to a very real problem in terms of mental health services generally, because if we haven't got data to measure the level of the problem, how can we help find a solution? And why is the data so poor, Professor O'Neill, in your opinion? And in this day and age where we collate everything and analyse everything, why specifically around mental health services is the data so poor?
I think, as Nicole said, it wasn't designed, the data collection systems in each of the trusts weren't designed to provide the sort of evidence that we're looking for. And the surveys haven't been commissioned. There's government surveys that will give us the general level of need, but we don't have enough of those prevalence surveys, the population surveys, to go into detail about how many people out there have the various different conditions. So we need to be doing a lot more. We need to be investing in research as well. And we need to create that single regional mental health service and implement the regional outcomes framework. But if they're in a regional model, the data would be collected in a consistent way using the same definitions, and the data would be available, and Encompass would allow that to happen. But the trusts working in isolation, essentially setting up their own systems, capturing data to meet their needs, data that's helpful for them and helps them understand what they're doing. That's the legacy that we're dealing with here, but we have the plan to change this.
And that as well, it's not unique to here. The Office of National Statistics met with us, was it a few months ago? Mm-hmm. There was a review on how mental health information was collected in England and Scotland and Wales, and they have different dashboards and things, but a lot of work preceded that to look at what administrative data already existed and how you could glean that information off different systems that already exist that were set up for different purposes. Mm-hmm. We're just grappling with the same thing here. It's not about having to create a whole new system or a whole new recording system, but how do we take what we already know and funnel that into our mental health outcomes so that it feeds both. Okay,
thank you. Colin, briefly, and then we'll go to Padraig.
It's on this data situation, and you've just touched on it there, and it's where I wanted to pick you up, Professor, is on the Encompass system. So and we know it's been developed at huge cost, potentially 300 million. It's now being trialled in the South Eastern Trust at this point in time. My question is, will that include mental health data that we can use? And if yes, will that help? And how soon? If not, is that a terrible mistake that we need to rectify very quickly in terms of Encompass?
So looking at the regional outcomes framework here, the implementation of EPIC IT system under Encompass does provide the opportunity to do this. I'm not across what's happening on the ground with Encompass. I met with them in the early stages the first few weeks and months this is happening. We need to be able to do this. So they received that message loud and clear, but a lot of it was already designed at that stage. So that's something we will go and check and find out. Maybe I'm very naively assuming that obviously that would be the case. It must. So we will check it. But yeah, we will certainly check that. It should, though.
And the department will be here next week.
Yeah, and that's something they'll be able to answer as well, because they're across the whole system, yeah.
We hope. Padraig?
Hi Siobhan and Nicole. Just checking firstly, can you hear me okay?
Yeah, loud and clear.
Great. Well, look, firstly, thank you. We're obviously doing a huge body of work through the Mental Health Party Group, and that's around early intervention. So that's the topic, unsurprisingly, I suppose I want to touch on. You've both already done a huge body of work on it, but I'm keen just for two specific questions, really. First one is, do you think that at the minute the Department of Health are putting enough priority on prevention services?
Prevention services, so interventions at an earlier stage. Yeah, it's a difficult one. I know that statutory mental health services would mainly deal with the step 3 and step 4. So we're talking moderate, severe end of things, and the community and voluntary sector would. But that's, you know, the community and voluntary sector work across the whole of the steps. But in terms of the C&V sector, the investment, a lot of the funding has dried up. So they would be delivering a lot of that preventative work, and the funding streams have run out. Department of Health will tell you that the 1-year funding is the barrier there. So where you don't have the 3-year budget, you can't provide 3-year funding for the C&V sector organisations. We did have the Mental Health Fund. Again, the money has run out. Though that fund was about providing interventions to address the impact of the pandemic on mental health. So that money was a one-off pot of money. But unfortunately, many C&V sector organisations have been relying on that for their survival. And now that money has stopped. So we do have a problem, and I think in terms of investment in the community and voluntary sector, there is an issue there. There's a finite pot of money, and the higher level, the more severe mental illness, the statutory services is very costly as well, and that's sucking up a lot of the money. But we do need to be doing the earlier intervention. The work that's happening in schools is very, very impressive. We just need to make sure that it is in all schools. You know, there's emotional well-being teams in schools, professionals in schools now, from Department of Health, health professionals working with schools to create that all-school approach to well-being and to work out what unique things are needed in each school, you know, to make things better there. So that's an example of good practice, and there's lots of work happening in communities through those community structures as well that we don't hear enough about, you know. So, but I'm concerned about the C&V sector funding, you know, in terms of your question, Padraig.
Yeah, thanks, Siobhan. And I mean, definitely the point you've touched on in schools and having, you know, while schools will do their own thing and I suppose have different programs that they run. I think what we've clearly found through the Mental Health Party Group is that there needs to be a baseline and I suppose a bare minimum of exactly what schools need to do and what they need to do, and that because some schools are really leading the way. I think all schools are trying their best in difficult circumstances, but we need to establish a baseline for what schools need to do. Second question was just around how you measure that. So early intervention, obviously something that I think I don't want to speak for other members, but I think there is agreement across the room that it's vital. One of the things about it, but is how do we measure that? I mean, how do we measure it firstly in the short term? In the longer term, obviously, you're going to see health outcomes over 10, 15, 20 years. But in the short term, how do we make sure that that's accountable? Do we use certain models? If we are using it through schools, how do we measure that? Because one of the things that obviously we look at it in this committee is to make sure that we're doing things as best as we can as we go along, rather than getting to an end stage and finding that something worked or didn't work. So I'm very keen that we go through that process and actually evaluate as we go along. I'm really keen to hear your thoughts and any suggestions on how we measure that, both quantitatively and qualitatively as we go along.
Well, my view would be that we need, and the paediatricians are saying this as well, you know, we need child health records from birth right through, I would say right up to, you know, if you're going to catch 50% of them by the age of 14, we need to be measuring this regularly as we go. We need to be looking at the whole child. So it's their physical health as well, and their relationships. So I think this is really important. We do need to be doing that. So the health visitors, the work they do is fundamental to this, but yet we see cuts there, and children that aren't getting those face-to-face assessments, when they're toddlers. That work is really important, and there are key things you can be looking for across childhood. And we do it well in the first 3 years, having gone through this as a mummy myself. The data is collected, there is that sort of oversight, but it does fall off, and there's opportunities within the education system to do this. And to do it well. So we should be measuring child health outcomes at intervals, and so that we can intervene early. And we should also be vigilant in schools for signs of problems and get that link between education and health. And I think those links are being developed, and that's really good. But there's no substitute for really measuring this and recording it as we go. It will make a huge difference, because we will be then able to benchmark against other regions, and we'll have all the physical health stuff as well.
And I think
that's great.
Can Nicole come in on this as well? Sorry, Patrick.
You've heard me talk about this before, but the framework for schools, they've built in continual evaluation processes. So at the minute they've 2 consultations out. One asking schools what services they're actually using, and the second one asking the C&V sector which services they're providing to schools, to get that kind of benchmark. The services that are set up within the emotional health and wellbeing framework are routinely monitored. They're asking how many young people they're reaching, is their satisfaction with the delivery of the service. Now, the caveat being that a lot of those services are very young, like they've just had the staff in place. There was recruitment issues again because of the budgeting concerns. But that process is continual and should be continual throughout the life of that framework, which is DE and DOH. They both fund it. So things like that at a programme level can tell you if it's value for money. Are people actually using it? And how that looks at a wider regional model. It is a regional framework, but those will be departmental reports that are put out so that people can see where the money's being spent in early intervention and prevention within the school setting. So it's whether or not we could potentially use that framework in other settings, but again, it just depends on the type of intervention you're looking at and where your markers would be.
No, that's really useful. Thank you both for your answers and for all your ongoing work.
Thank you. We will move on to Cheryl.
Thank you, Chair, and thank you so much. This has been fantastic to hear all this. Just in terms of education and then that early intervention piece, there's recent reports suggesting that access within the schools is variable. I am cautious around data that you may not have this information, but how widespread are these problems?
In terms of access to mental health services, it's impossible to know is the answer, but parents are saying they can't get help for their children, and that they can't get access to child and adolescent mental health services within the time limits, or there's long waiting times, or they don't meet the criteria for CAMS, so they don't fit within the boxes that the system. But parents will go then to other services in the C&V sector, maybe not the right services, but they're getting something, where they'll pay for support themselves, or they'll go to a private service. So it's very, very difficult to know what the state of play is. We have been in receipt of the CAMS data set from Department of Health, because all of the data is collated together. So Nicole's looking at that, and we've looked at it together, and there doesn't seem to be an increase in the waiting times for CAMS generally. They remain too high, but there hasn't been like an increase over the last couple of years that we could, they've sort of remained stable, but the reports can be very concerning. We were talking to the Belfast Trust around their experiences in terms of eating disorders, and it's just really worrying, the change, the more serious cases needing hospitalisation. Very, very, very worrying, but we don't have then the data for the other trusts, so it's hard to know
I'm just thinking within that kind of educational setting and the school setting, but is there a way that you can see the Department of Health and the Department of Education working better to deliver on these services?
I think the main one would be, so if you look at the CAMS data set, we know primarily the majority of referrals to our CAMS service comes through GPs. Yeah. When we speak to schools, the opinion is we can't refer to CAMS, we can identify when there's an issue that we can't deal with, but we don't put that through. We advise them to go through GP, to go through that medical route. The team that produces that CAMS data set will tell you that you can go through education, you can have that referral. I don't know if you've ever seen a referral to our CAMS service. It'd be quite time intensive, and obviously our teachers are under a lot of stress and have a lot of demands on their time. So it's figuring out a process where they can communicate better. And I know the Wellbeing in Schools team having that link with our Department of Health, with health professionals on the ground and the campus, that those conversations can happen more fluently. So if it is a case that it's an issue that a young person has, that they are definitely in crisis, that they're experiencing distress, CAMS might tell you that it's not at a level that they should be intervening, it's not at a clinical level. The school and that young person is still in a position where if they can't find support in their local community, if they are in a rural area that's not very well serviced, or local supports have lost funding recently and services have closed, then they really are in a position where the school doesn't know what they can and can't do, and they often fear doing the wrong thing, because we all do with regards to mental health, but having that relationship with a health professional that you can have those conversations and understand that our teachers are very, very skilled. They deal with young people day in, daily. Like, they know how to support them. They know when there's an issue. But when it comes to mental health and anything health related, they just need that assurance from a health professional that their approach is okay, that you can support that child in their education environment until such times as a service does become available, or if it is clinical care, that's clearly identified early on and they're not left in this grey area where, as professionals, they don't understand if they've done enough and fear that they haven't. So it's the relationship between how they work, but there is movement in that, and it's very positive. Where it works, it really works well.
No, appreciate that. At one of the education committees, you've done a fantastic presentation and report, and you just highlighted around SEN provision and support. And it's a huge issue, and it's a particularly vulnerable group of people as well that aren't getting the support they need. So it's just to get your opinion on that, how you think we can move forward, or what has been done currently to support children with SEN and mental illness.
I think it's important to say that the support that we give to children in the education setting improves their mental health, because it is about emotional regulation, about making sure that they're content, that the environment is not overstimulating, or that that the environment can meet their needs, and that's really what it is. So it supports, by providing the educational support, you're supporting their mental health. But the delays in getting the assessments, the lack of services, particularly around autism, but ADHD as well, the lack of awareness around neurodiversity generally is a real problem there too. So we need to raise awareness across the education system, but we need more specialists there, because there is an increase in the numbers of children with these conditions, and they can be, of course, in mainstream education and should be part of the school communities that we have, but it's just that their needs need to be met, and then they will not develop mental illness. So this is not, we're not talking about children who are mentally ill. We're often talking about children who are neurodivergent, but they need support so that they do not become mentally ill. But when they do become mentally ill, we don't have mental health services then who meet their needs. And I've had parents say to me that my child has autism and therefore they can't get treatment, because the trust's saying we don't have anybody here who specialises in autism and treating people who are autistic or with a mental health problem. We don't have expertise in that. And that's the difficulty that we're seeing. Again, if we expand the workforce for mental health, we will have more people who are equipped to meet the needs of autistic people, for example, with a mental illness, or someone with ADHD who may be at risk of having a mental illness or who needs medication to manage their ADHD. So there's a lot of work that needs to be done there, and in the meantime the rates are going up, and we don't know why that is. There's various different theories, but we need to meet the needs of these young people so that they don't miss out in key years of their education.
And just in terms of children with mental health, do you think there's sufficient cooperation between departments to support children's mental health, for instance, education, justice, communities? There's multiple departments, and is there any evidence in your view that the requirements of the Children's Services Cooperation Act 2015 is being met?
Okay, so I'll start, but then I'll very quickly pass you on to our expert on the Children's Services Cooperation. So is enough being done? I think the framework was a game changer. We have health and education working together, and I sit in steering committees where we have health, education and justice sitting together, whether it's crisis services, or children and young people, whatever it is, the education framework, they are there, they're motivated, engaged, and part of the decision-making process. So that does happen. However, education are very clear that their goals are about education, and the outcomes, when we're talking to education about outcomes, they are thinking about qualifications as outcomes, and the mental health piece is different. In health, they're about treating mental illness. So you've got this piece in the middle, which is well-being. It's what is it? Where does it fit? And that's why I'm talking about a program for government that really focuses on this, because there's so much in communities there, housing, that's absolutely vital to mental health and well-being. So they do work together, but when it comes to budgets, they like to stay in lane because they can't be spending on something that's not an outcome, and that's fair enough. I totally get that, but it does make life more difficult when you're trying to fund something like the framework, which can't be, it can't be mental health, because it's not about treating mental illness, but there's mental health in it, and it's funded through both departments. But I worry where you've got a situation where the budgets are very, very limited, that they'll be moving back into their lanes and looking at their outcomes and what, strictly speaking, they have to deliver. And that's a problem. It's also a problem with justice, but justice are delivering a lot of mental health treatments that they feel health should be paying for, but they're delivering them because the needs there are just huge. I mean, the majority of people in the care of the justice system, particularly in prison, would have significant mental health problems resulting from trauma. So that's what they're dealing with, and they're paying for that through their budget.
So is it safe to say, and I'll move on then, is it safe to say that the silo mentality of departments is resulting in the requirements of that Act, the Children's Services Cooperation Act 2015, not being met?
I think the challenge around that one specifically, the legislation, I actually think it has an incredible potential, because it is cross-departmental, and it has that action where for funding, it doesn't necessarily mean that DOH does this project, DE does this project, and people stay in their lanes and have their own outcomes. What it does is give the legislative power to pull those resources to say, well, what do our children and young people need? What services do we need to surround them with to actually do that? And this is the joint pool of money that can accommodate that. There was to be a report the last time our executive had sat, but obviously in the interim there was the instability, so that has never been produced as to look at how often that power was even utilised, how it functions through our finance department. Is there mechanisms in place that facilitate that and at a larger capacity? Again, without that information, we don't know, but I do think it's a very unique document that hadn't been done before, so it might require specific procedures to be put in place, not extra money to do it, but just the actual process of how you would go about sharing those, so that it has departmental oversight from lots of different departments, but not one can claim separate projects within it, if you know what I mean.
this Act is specifically to meet the needs of children, and I understand that, and multiple aspects of life can affect a child's mental health. But if a child's mental health is poor as a result, for instance, as the impact of the cost of living crisis or deprivation, then they're not going to be performing well in school. So that has an impact on the output of education in schools. So really, if this Act is not being adhered to or the requirements met, the outcomes fail everywhere. So the cost of that is significant. And that's the point that I would make.
I would note that the Department of Health in their budget plan, it's the first time that I've ever seen it. Now, I've only been in this position for a number of years, so it may have been there before, where they have a detail in it that budgets might change if there's any demands on it from the Children's Service Cooperation Act and that pooling of resources. So the acknowledgement is there that it can be used. I'm just not sure to what level it has already been.
Okay, no, that's helpful. Thank you. We'll go to Colin, then we'll go to John. I think Cheryl. Is it? Yeah, I got you, Cheryl. I don't know.
Our work here is nearly done, Mel.
Just
Been covered on it.
Go on again.
Just building on that question of yours in terms of working between departments, are we doing enough between departments? And going back to the auditor's report where she identifies that 1 in 6 of young people exhibit indications of an eating disorder, in relation to that specific or that type of service or need, are we working closely and cooperatively enough across the island? Because a number of months ago I became aware that there wasn't a single bed for a young inpatient bed for a young person with eating disorder here in the north. But I became aware there was some capacity in the south. But could we be cooperating, and do we need to be cooperating better in some of these specialist services on an all-island basis?
Yeah, we could, and we need to be. It's the only way. We've got to maximise what we have to benefit everybody. It's essential. And I have regular engagement with Minister Butler, who would be responsible for mental health in the south. And we do this. The Shared Island Unit are funding work. They're doing a digital mental health piece that I'm involved with. I'm leading on that. That's looking at digital interventions both sides of the border for young people. And doing the work together. If you look at the two strategies, they're very, very similar, sharing the vision and what we have here in our mental health strategy. So there is the potential for that working, and indeed levering and funding. The Peace Plus monies, a lot of them will effectively fund health interventions and mental health interventions and early intervention. And again, I sit on the monitoring committee for that, and I've advised in terms of the direction of those projects. So yes, we're doing it. We need to do a lot more of it. We need to work smarter here to make sure that we have the services, particularly for conditions where you've got that low prevalence and you need the specialist services. But in terms of eating disorders, it's very good for the person to be located close to their family. The Maudsley model is the model that we should be implementing, and that is first of all about nutrition. You stabilise the person's nutrition, and that means that they will maybe require a hospital bed. That's not an eating disorder unit, but just to get their weight back up again. But it's so important that you work with the families, so you wouldn't want people travelling too far for those inpatient services. And equally, we discussed it in relation to the mother and baby unit. Again, there's conditions where people need to be close to home and their families. So this is a tricky one. We need to look at what we can do. I'm having the conversations, and you're pushing an open door there as well with Minister Butler and the government in the Republic as well. So let's get more of that if we can.
Okay. Members, is there any other questions that you should like to raise?
It'd be useful, Chair.
You've been extremely patient. We really do appreciate you being here and for taking our questions. Is there anything else that we haven't raised with you that you would like to maybe raise with us?
Well, no. I mean, only thing I'm looking at is when I said the psychiatry vacancies are actually worse. So I 16.4%. The true consultant vacancy rate is 24.6%. So that includes locum and vacant consultant posts. We'll send you some of this data, but it's just 16.4% there as an underestimate. In psychology, it's a 30% vacancy. That's what we're dealing with, So, yeah, I think that's the only thing I wanted to clarify. There's been a lot there. Happy to take questions as you go through your inquiry. Other things will come up, and you may want to ask our perspective on that. And we can go off and give you a view, as well. So please feel free to do that. We think it's really important that you're doing this work, and really happy and keen to be involved in shaping this too.
You think we're in a mental health crisis?
I don't use the word crisis because I think that creates more hopelessness and a sense of distress. When you look at the proportions, they're similar to other regions. Things have gotten worse in the past number of years in those other regions as well. But we have significant unmet need, and the cost of it, 3.4 billion annually, and this is preventable costs. The preventable suffering, suicides are preventable. We have 200 deaths every year. It's costing us 1.5 million. We're putting 10 million into our suicide prevention strategy. That's just not good enough. So whilst I don't use the word crisis, it's just appalling that we're still in this situation. We've been talking about it for so long. I've been talking about it for so long as an academic. And we have the plan, but we're not implementing it. And that's just such a shame. And my worry is that this plan, that people have invested themselves, people with mental illness who've had significant suffering and trauma in their lives have come and helped us develop this.
Yes.
C&V sector services have worked, they've taken time out, unpaid, to develop this. And it's not been implemented fast enough because we can't spend the money. We know we're going to get it back. There's very few other areas where I can see the very clear economic argument. When I listen to the radio and people are talking about spending and this and that, the economic argument for this is really, really strong, but we're not doing it. So that's the bit... and with our children, we can't buy this time back. So, we need to be doing this. And we will get it back. You will see the difference in our economy. You will see the difference.
Thank you. Dan, briefly.
Yeah, thank you. And just, you had referred a number of times to the Regional Outcomes Framework for Northern Ireland. Is that a published document? I would just like to have a copy of it to hand, whether it comes from yourself or the Department of Health. I think it would be good to...
I got my copy because I'm part of the group that developed it. So I don't know if it's been finalised, if it's been signed off. I'm working from the last draft. That group has produced this, but of course these things need to be scrutinised by a minister and signed off, and I don't know if that has happened just yet. But if it has, we'll send it to you. We'll keep a note of that. And I can update you then on implementation as well. We'll ask this question again, but that's the document that I got, was the last version of it. So
thank you.
Thank you. Can I ask the CNAG, have you any questions for Professor O'Neill? No? Okay, thank you. Professor O'Neill, that was an extremely powerful contribution and a really deep insight into a lot of the challenges that our society face. And I think this is a hugely important inquiry that we're about to partake in. This evidence session today will have informed members on the very real reality, but also, which I found really fascinating from yourself, is the real focus that the solutions are there, and that this assembly and the departments need to take them up and implement them in the interest of people. So we do appreciate that very much. The TOA, have any comments?
Thanks, Chair. Just a couple of brief observations. I suppose from a finance perspective, I think it's been a really helpful session, and commend the witnesses for that, and the committee as well. I think from a financial perspective, there's a huge amount of energy and effort going in at the moment. The members of the Finance Committee will be aware in terms of the work on the 24/5 budget, but also the longer term sustainability piece. And I think the Audit Office report and the witnesses' comments today have provided very clear evidence to help make a compelling argument in regards to funding in terms of need. I think that's been really helpful as well. I also know the comments in terms of multi-year budgets, which also I think is very helpful from the OF perspective. In many regards it's outside our control, but I think it's a very important point to make, the importance of delivering on strategies. So that's not lost on us. I think the very impassioned comments around the potential savings. We cannot lose track of that as well, given the issue around sustainability. I think invest to save was a comment Mr.
Yes.
used earlier, and this fits exactly into that agenda. So I think that's important takeaway for Department of Finance as well. And I also think it was interesting about the funding model for your own office. And given the likelihood that there will be funding gaps here moving forward, I think it'll be very interesting to hear the comments of the department next week maybe around that model, to see if there's any potential to use that moving forward to help limit the gap. So those would be the key takeaways from me, Chair, if that's okay.
Thank you, Stuart. And thanks again. Is there anything you'd want to respond to? Is you happy?
No, I mean, the 13 million in antidepressants, that's the cost of it as well. That can be reduced. People are saying they want psychological therapies, they want therapies, they want counselling, they want alternative interventions. You know, the research is there to show that there are other models, that these are treatable illnesses, so we need to be doing the work.
Thank you very much, and also thank you for the important role that you play as a very powerful voice and advocate for all of those out there that battle every day and are seeking that help and support. And it is important from this committee that we do reassure the public that the help is out there. It's just about finding the right route and getting that support as well. And also thanks to you, Nicole. We do appreciate you both being here. This has been very informative, extremely helpful, and has set us in a very solid foundation for the inquiry which will begin next week. This is a huge issue for all of the people and families right across Northern Ireland. They'll be very happy to see this inquiry begin, and we'll look forward to the outcome and the publication of the report on the 20th of June, which is what we're aiming for. So thank you again, Professor O'Neill, and thank you, Nicola White, for being with us.
Okay.
Okay, members, we're still open, yeah. Members will be moving into closed session for the remainder of the agenda, but I'm sure everyone will agree that was extremely helpful, very, very powerful.
There's no words on the chair.
Okay, thank you. Thank you. Thank you.
We are, thank you.
Okay.
Thank you, Stuart.
Yeah, that's tiredness and coffee.
I think they're going to be 15 minutes. I might just leave.
Okay, members, we'll be moving into closed session when the team.
Committee Room 21. Sound. Committee Room 21. Sound. Committee Room 21. Sound.